Healthcare in Belgium is composed of three parts. Firstly, there is a primarily publicly funded healthcare and social security service run by the federal government, which organizes and regulates healthcare, independent private practitioners, and public, university and semi-private hospitals and care institutions. There are a few private hospitals. Secondly, is the insurance coverage provided to patients. Finally, industry coverage, which covers production and distribution of healthcare products, and research and development. An important part of this research effort is done in universities and hospitals. Organization. Healthcare in Belgium is mainly the responsibility of the federal minister and the Volksgezondheid en Sociale Zekerheid (SPF Santé Publique, Sécurité Sociale). Responsibility for some matters is delegated to the authorities of the communities, but in practice these responsibilities are exercised by the governments of the Flemish and Walloon regions, and the German-speaking community. Both the Belgian federal government and the regional governments have ministers for public health and a supportive administrative civil service, political and regulatory organization of care. Generally speaking, healthcare is organized in three layers. First line, the primary care function that is provided by physicians, emergency services and ERS in hospitals. Polyclinics provide non-urgent first-line care. Second line, acute and immediate care provided by hospitals for patients requiring technical interventions and acute curative care. Chronic and long-term care is provided by rehab clinics, service flat care providers, old age homes and home care services. Physicians, the prime care professionals that patients need are the GPs. For common diseases like cold, flu, injuries and little aches, patients contact their GPs. Physicians in private practice are generally self-employed. Officially, they are categorized in the following framework. Private practice. General practitioners usually operate from the private practice, although some group practices are emerging. These doctors are also syndicated in local chapters that organize guard duty services during weekend and holidays and for the evening hours and during vacations. A patient can call a duty GP 24/7 who has access to the patient's medical records from the GPs. Specialists, many combine the private practice with a hospital posting or with a teaching position, a similar research posting. Only a few operate private clinics. Experts and assessment consultants. These specialists don't see general patients. Rather, they evaluate patients either as a second opinion at the request of the patient or are appointed to assess patients and treatments for insurance matters or by appointment of a court. Clinical practice. Specialists. Many clinical specialists have a teaching position in hospitals or combine the hospital position with a teaching position at a university. Research clinicians run clinical trials and do research. Most doctors working in hospitals also have a private practice. Exceptions are, for instance, neurosurgeons or radiologists. Doctors are usually paid on a per medical act basis either by the patient at the private practice or by the hospital. However, some specialists are employees at a hospital's payroll or for research labs or universities. Assessment consultants are paid a fixed fee for their assessment report by whoever hired them. Emergency services. For accidents and medical emergencies, everybody can call on the emergency services. There are two phone numbers to contact the emergency services network: 100 or 112. 100 gives you access to the ambulance service or fire department. In larger cities, the fire department operates the ambulances. Elsewhere, ambulances might be allocated to hospitals. 112 gives you access to the police, ambulance services and fire department. The dispatching centers for the 100 and 112 services dispatches an available ambulance from the closest hospital or ambulance center. The operator is qualified to decide to dispatch a mere vehicle. Hospitals and the fire department operate ambulances in some hospitals. Additionally, the Red Cross charity operates a number of ambulances as well as privately owned companies that operate ambulances for the emergency network. The Red Cross charity and a number of other cross charities own ambulances and have volunteers that man first aid posts during events like football matches, cycling races, sports, or other mass events. They don't participate in the daily emergency services network, but they liberate the emergency services network from allocating too much assets and resources during those mass events. Calling an ambulance is not a free service. The ambulance will bring the patient to the nearest hospital. An ambulance is manned by 2 people, a driver and a paramedic. Depending on your medical condition, a MIRV, medical emergency response vehicle, is dispatched. The vehicle is manned by 3 people, a driver, an ER doctor and a senior ER nurse. The ER doctor will choose the nearest appropriate hospital that has the necessary facilities based on the patient's symptoms and condition, or another hospital in which the patient is under active treatment. Hospitals. The Federal Service for Public Health describes the hospital sector in the following manner. General structure. There are, generally speaking, 2 distinct types of hospitals: general hospitals and psychiatric hospitals. Psychiatric patients are not mixed with general hospital population. There are 209 hospitals subdivided in this way. 68 psychiatric hospitals care for psychiatric patients that require care in a controlled, restricted environment. Some of these hospitals also offer therapy day clinics for patients that stay at home. 141 general hospitals which, as a general rule, are involved in providing non-surgical care for primarily adults with services such as cardiology, pneumology, gastroenterology and endocrinology. They also provide a maternity ward and most of them have an emergency response unit. Pediatric and geriatric care units are available for those particular types of patients. 113 general hospitals function as acute hospitals, 7 of which are university hospitals. They are directly linked to universities and provide for teaching and research facilities. 16 general hospitals with university status that have special provisions to collaborate with universities and colleges both for teaching and research purposes. 20 specialized hospitals that are smaller and provide care for very specific groups of patients like heart and vascular diseases, pulmonary diseases, locomotor disorders, neurological problems, palliative care, chronic diseases, or psychogeriatric care. 8 geriatric hospitals with care specifically for the elderly and the particular health problems. The vast majority of hospitals are publicly funded. They are independent units, a part of a larger organization that get funding from the public health service based on the activities they deploy, number of beds operated, specialist knowledge, etc. In Belgium, there are only a handful of privately owned, operated hospitals that work outside and without the public health service funding. They provide luxury services and luxury accommodation for patients that can afford such exclusive services. Outside these categories there are day clinics where ambulant patients can have therapy and return home. Many hospitals have sections for day clinics, polyclinics where different specialists see patients who do not need to stay overnight in the hospital for diagnosis or post-therapy control. Many general hospitals operate polyclinics, but there are institutions outside hospitals that operate only as a polyclinic. In a general hospital, any of the following departments may be at the disposal of patients, but not all general hospitals offer all these facilities and departments. Emergencies and trauma center, usually backed up by an ICU, or not all hospitals provide surgical treatment and ORs. Polyclinic consultations, ambulance or outpatient care. Patients can come during office hours to see a specialist either in the diagnostic phase, therapeutic phase or post-therapy follow-up consultations. Technical interventions. Technical interventions are consultations using diagnostic tools such as collection of blood or bodily fluid samples, and lab testing, medical imaging, EEG, ECG and extended monitoring outside acute illness situations. Nursing units. Standard hospital ward type of sections where patients get 24/7 care post-op recovery. Specialized units may be sections in a broader general hospital, independent units within a general hospital, or independent specialized clinics. Neonatal and pediatric clinics, rehab and recovery clinics, geriatric clinics, palliative care units, psychological assistance units. Research units. Units within a general hospital that are specialized in running and caring for and following of patients, participants in clinical trials. Nursing. Different levels of nursing training are available: basic nurse, midwife, full nurse. Nursing in hospitals. In hospitals, the nursing work ranges from basic care nurse, nursing assistants, full nurse, chief ward nurse, trauma nurse or paramedics, aurora nurses and chief nurse. Each of these positions require a different level of formal training, on-the-job training, accumulated experience and responsibilities. Nurses seldom work over the competence, because according to the Peter Principle, it would cause casualties. Nurses in care units work shifts to a 2 shifts per day and 365 days per year. Many nursing wards in general hospitals are currently chronically understaffed, exceptions being a or an ICU. Some post-surgical wards such as cardio, thoracic and neurosurgery units that operate MCMUs often are less prone to understaffing because of the risks involved for patients. Nursing in research and polyclinic environment. Nurses in research and polyclinic environments often have a more family-friendly and limited 5D, 8 hours, D working patterns than their counterparts in the hospital care nursing units. However, not all nurses like to work in such environments. Ambulant nursing. When patients go home, they often require follow-up of the hospital care like wound dressing, injections and bathing. Specialized ambulant nursing services provide such nurse-at-home services for recovering patients and for elderly people living at home. These services also dispatch basic care nurses that do not perform medical acts for patients and elderly that require help with the daily hygiene and changing. Pharmacy. Main street pharmacies. Drugs and medications can only be sold by pharmacies. Supermarkets and diet shops can sell products such as over-the-counter food supplements, but any product claiming a medical effect, even over-the-counter painkillers or stomach tablets, are limited to pharmacies. Hospital pharmacies will only dispense drugs and medications for administration by nurses and doctors in a hospital environment. Many of these products are not available over the counter. Distribution of care products. Companies that wish to produce, import and distribute substances that can be qualified as medicinal are required to have a license and are strictly monitored. The stock movements are controlled by a very close monitoring system. Internet medication. If a patient buys medication in another EU country from a pharmacy for his personal use by prescription or over-the-counter, he can import them into Belgium in his luggage or vehicle. Belgian patients may legally buy over-the-counter painkillers such as paracetamol in the Netherlands where they are cheaper, and take them to Belgium. However, attempting to import prescription drugs without a prescription, unregistered or forbidden medication, or narcotics purchased on the internet or for recreational drugs illegally on the street is prohibited, and customs and police track this business rather strictly. Illegally imported drugs are confiscated, and the carrier might be brought to justice and fined or imprisoned. Health insurance. History. May 26, 1813, after a mine pit disaster in Awadh, an imperial decree created a miners' fund. It is financed by the employers and workers, and which pays miners an allowance in case of permanent disability or medical incapacitation. September 19, 1844. A welfare fund, de hulp en voorzorgsverzorging onder Belgische VLAG, allowing workers an insurance-like cover against illness, disability, old age pensions, work-related accidents and unemployment. April 16, 1849. The government subsidizes the cost of incorporation of the Societies of Mutual Assistance. May 8, 1850. The government creates the Algemenliche Frontiers, where every Belgian can save money for his old age pension. 1869. Incorporation of the first socialist mutuality, La Solidarité at Fait Les Manage, the forerunner of SOCMUT, one of the three most important entities in the modern Belgian social security system. 1894. The first national law concerning the finance and provision of health care in Belgium was enacted, with social insurance being introduced in 1945. Working health insurance is only one of the pillars of the system of social security provided for every Belgian citizen. Every Belgian citizen has access to the social security system. It is compulsory, but there are gaps in the system where people can drop out. For example, not paying contributions is one such exit, and another is homelessness. Financing the system. Compulsory social security. Every wage-earning worker or employee in a factory, office, working as house personnel, and anyone working in Belgium is registered to a central system, as well as the unemployed. The self-employed, such as shopkeepers, innkeepers, lawyers, and doctors, are also registered. Workers are paid a daily or monthly wage, the gross salary. For that gross salary, their employer has to deduct a certain amount for social security and another for taxes. The employer has to pay these amounts directly to the Social Security Services and the Inland Revenue Service. On top of the gross salary, the employee has to pay an employer's contribution for Social Security of approx 15% to 22% to the Social Security Services. Failing to make these payments regularly and on time is closely monitored and often causes failing businesses to be taken to court for failing to comply with the Social Security and fiscal obligations towards the workers. This reduces the risk for workers when they remain unpaid or when their contributions are not paid for them. The self-employed have a system in which they have to declare their earnings, and based on their earnings a contribution is calculated, which is roughly 20% to 22%, but they are not covered like workers. People can opt into the system through this self-employed scheme. The government forms its tax earnings finances in part the Social Security system. This is a wealth redistribution mechanism, because the contributions are incremental. This means that the more someone earns, the more this person will contribute. Moreover, for health services, the compulsory health insurance and the refund system is the same for everybody, i.e. for a consultation at the GP everybody pays the same and gets the same refund. Financing the system. Complementary systems. There is a complementary system of health insurance offered by the mutualities, available to all mutuality members, and there is private insurance with commercial insurance companies for extended care and for travel care. These systems are pure premium-based insurance system, covering healthcare costs. 1. Consultations with GPs or specialists. In the private practice, patients pay a fee for the consultation and for any medical acts he may perform directly to the doctor. In return, the patient gets a receipt that lists all the medical acts performed, and if necessary, a prescription for medication. The patient gives this receipt to his mutuality, and they refund the patient in part. Average patients get about 75% refunded. Some patients have a special social security code. They pay only €1 to the doctor and do not receive a refund receipt. The doctor is paid directly by the mutuality. The patient takes his prescription to a pharmacist, paying only part of its price. For each medication dispensed, the supplier is paid a supplement by the Social Security services. In some cases, the medication requires extra checks, and such medication is often free to the patient, although very expensive. Each sale of the medication is tracked, and the supply paid by the Social Security services directly. 2. Consultations at hospitals. Patients see a doctor at the hospital polyclinic, just like in the private practice. Some patients pay the hospital as they leave and get a receipt for the mutuality, just like in a private practice. However, many patients come in for follow-up consultations after a medical intervention or hospitalization. The hospitals send the bill to the mutuality, and patients get invoiced for their personal part. 3. Hospitalizations and medical interventions. Patients are hospitalized and they have to pay weekly advances for the medical expenses. All consultations and interventions, medications, etc., are directly invoiced to the mutuality and insurance cover the patient may have. They receive an invoice for the personal part, which is often in part refundable by the complementary insurance. Patients who suffer accidents might never have to pay any medical expenses, as accident insurers are often charged immediately. Once responsibility is established, managing healthcare money streams. Private insurance. Private insurance companies collect premiums and provide cover. When an insured risk is realized, the insurance company pays. Legal systems protect patients, doctors and hospitals from abusive denials of refunds by insurers. A governmental complaints authority keeps an eye on policy conditions and execution. Access to private insurance is of course free. However, an independent ombudsman service oversees refusals to insure a termination due to changes in medical condition of the patient. A governmental arbitration service reviews patient cases referred to it by the ombudsman and determines fair conditions, premiums for refuses, terminated patients. Mutuality. Complementary insurance. The mutuality collects premiums and pays according to the selected cover. Mutuality's compulsory health insurance. The mutuality's front office workers evaluate any refund claims superficially. Is the medical act refundable and what rate, and refunds the patient nearly immediately. The receipt is controlled through the mutuality back office system such that one doesn't get double refunds and other abuses. Some claims incur supplemental refunds, which are sent by the mutuality back office to the patient's bank account. The mutuality gets paid by the Social Security services the amounts they pay as refund, a fee for operating cost. Mutualities have an extensive network of offices and the number of staff runs in the thousands. They also have large computer networks and difficult software programs that are often tailor-made. The patient's KETA system in the 80s and SIS card was introduced. The Social Security card With it, the federal government introduced a national number that identifies each individual uniquely based on his/her birthday. Every individual had such an SIS card, and it established their entitlement to Social Security. In 2014, that system was superseded by the plastic ID card with Social Security information on the card chip, readable with a simple card reader. According to the Euro Health Consumer Index, which placed it in 5th position in its 2015 survey, Belgium is probably the most generous healthcare system in Europe. Social Security. Social Security encompasses health, old age pensions, unemployment, disability and handicap, both managing the finances, but also the management of different kinds of care, regulation of the market of medicines, health and safety at work, health and safety of any public service rendered to the general public, monitoring and safety of the food chain, etc. Just the overview in the regulatory services involved at different government levels in Chapter 1 provides an insight in the complexity of the matter of Social Security.